overview of information. Some of it will be new, some of it hopefully will be old information to you. I am the Vice President and Chief Medical Officer for the Augusta University Health System and Associate Dean of Clinical Affairs for the Medical College of Georgia and a Professor of Emergency Medicine. The information about the coronavirus, I think, is kind of important to start with the basics because there is a great deal of misinformation that's out there, and I think it's important to make sure that we cover some of the basics. So first of all, coronavirus is actually referring to a group of common viruses that typically affect the respiratory system of mammals, including humans. They are associated with a common cold, pneumonia, and acute respiratory syndrome, but the virus is actually, or the group of viruses, the coronaviruses, are responsible for about 15 to 30% of the common colds. Coronaviruses are named because of their spike-like projections from the surface of the virus. They were first isolated in 1930 from an infected bird, and the first human coronaviruses were identified in the 1960s. Now, there are 7 types of coronaviruses known to infect humans. Unfortunately, humans can be repeatedly infected even with the same strain of the virus because the antibodies are not long-lasting. And antibodies from one strain of the virus are not effective against other strains. Now, there are 3 types of coronaviruses that are known to cause significant human impact. That is SARS coronavirus 1, or SARS-CoV, that was an outbreak in China from 2002 to 2004. And you see the number of cases and the number of the mortality from that. Middle Eastern respiratory coronavirus, which was 2012 and is ongoing but does not have significant ongoing spread right now. And then the current outbreak of what is now called SARS-CoV-2, or the lung disease that's caused from that is COVID-19. Now, transmission for COVID-19 or SARS coronavirus 2 is person to person and happens through close contact. Close contact is defined as within 3 to 6 feet of an infected person for greater than 1 to 2 minutes. The droplet spread of this is similar to that of influenza and other respiratory pathogens, and generally speaking, the majority of infections occur from being in close contact and then someone coughs or sneezes, expels droplets, and those are inhaled by the person being infected. There is some concern about survivability on surfaces, but that is unclear. There's some data to suggest that may be hours and some data to suggest that could be days. We do know, however, that it is easily killed. So this has an envelope, and there's good evidence to suggest that products that we know that are effective against SARS-CoV-1 are also effective against SARS-CoV-2 or COVID-19. It has a 2 to 14 day incubation period where the person may develop fever, cough, and shortness of breath. It's important to understand that the best evidence is that about 80% of patients have minimal symptoms. So they essentially have a cold, maybe a little bit of a low-grade fever, and that's it. And that's in 80% of cases. About 15% of cases develop severe illness and may require hospitalization. Now, I say a 2% mortality, but that is without knowing what the actual denominator data is. There is really good evidence to suggest that the mortality on this may be much lower because in China, where most of the numbers are coming from, for example, if people have minimal illness, they may never get diagnosed, they may never get tested, and therefore they had a minimal course and don't end up in the numbers. So that artificially elevates the mortality for this particular disease. Now, the current state as of 9/13 this morning, 115,855 cases worldwide, about 4,087 deaths. One thing that I think is worth noting on this slide is that if you look at this yellow line on this graph, those are the numbers just in mainland China, and you'll notice that that has leveled off significantly. China is now adding cases at a very slow rate compared to what was happening previously. There's a couple of different ways of interpreting that, but certainly whether it is because they're getting better infection control and better identification of cases early, or whether it's quarantine and isolation that is controlling those, or because a large number of people have already had their course of the illness and are now immune to it for a short period of time. In the United States, as of 9/13 this morning, we had 756 cases confirmed to date. 17 of those are in Georgia that are confirmed cases, but none locally. We have had about 26 deaths in the United States, and currently we have a wide geographic distribution. So there's a couple different ways to interpret that. One of the things that may be happening here is that as we test more for this disease entity, we find it more often. And it may be a new awareness of an existing problem rather than a rapid development of new cases. And we just don't know which that is yet, and have to kind of interpret it both ways and prepare for both. Now, all of these numbers look scary. You know, when you see all the red dots on the map, and especially when if you've seen any of these maps where it consumes the whole country, it all kind of looks really scary. And one might think that, you know, like in Game of Thrones, the White Walkers are coming, and brace yourself because winter is coming. But that really should not be the case. The reality is that when you put these numbers in perspective, this pales in comparison to the flu. So worldwide, about 250,000 to 500,000 people die every year from the flu. In the United States alone, it is estimated that we have anywhere from 9.3 million cases to 45 million cases of the flu. We have hospitalizations ranging from 140,000 to 810,000 cases per year, and from 12,000 to upwards of 61,000 deaths from influenza in the United States every year. So when you look at those numbers, as scary as they may seem, they really do pale in comparison. And essentially we could think about this as just a really bad flu season. Now, when you think of it that way, what do we do to control the flu? Well, we have some different methods that we use to control the flu, and one of those is to reduce exposure through good hand hygiene and through using hand sanitizer and good cough and sneeze etiquette, and the other is to vaccinate high-risk populations. And unfortunately, one of those is not available to us right now, and that is the option of vaccinating. So there's currently no vaccine. It has been fast-tracked for development, and it's currently in animal trials. We're estimating a timeline of anywhere from 6 to 18 months. 6 months would be really aggressive and optimistic, but certainly possible, and they've been moving very rapidly on the development of a vaccine. So if a vaccine option is not available to us, what can we do to help spread the control COVID-19 and the novel coronavirus? Well, we use different techniques, and that being infection control methods, social distancing, and quarantine and isolation. So simple infection control methods, good cough and sneeze etiquette, washing your hands, using hand persons who are well but may be exposed to COVID-19. So, for example, a person that has had contact with a confirmed case would be asked to quarantine at home for 14 days and monitor for symptoms to see if they had developed the disease. That's to reduce any potential that this person might become ill and be out in the public and potentially infect other people before it becomes apparent to them that they are ill. So that is quarantine. That is taking a person who is well but exposed and essentially eliminating contact with other people to reduce the potential for spread. And then isolation. Isolation is used for someone who is ill and is either suspected or confirmed to have had COVID-19, and essentially they remain at home. or in a hotel room or in a dorm or designated location, so that they minimize their contact or eliminate their contact with other people to reduce the potential for spreading either the disease that they have or if it's COVID-19, to eliminate that. So think of this as, if you're ill, you go in isolation. If you're well but exposed, you go into quarantine. And that's a way to separate those two out. Now, that sounds terrible, again, but the reality is that may just mean that it's Netflix and chill, right? So it may be that you just binge watch Netflix and you stay at home for a couple of weeks. It doesn't mean you can't go outside. It just means that you're not going out in public. Now, persons under investigation, the criteria for this is developing, and that is that as we begin to see more geographic spread of this disease in the United States, meaning community spread within the United States, that the travel history component of this will become less important, and really it will become an issue of identifying people that are at risk. We have the advantage that we're coming off of flu season. Flu is starting to diminish within our community, and that's a big advantage for us. And basically, when we see patients that have fever and signs and symptoms of lower respiratory illness, we will probably start focusing on that as being the risk for COVID-19, and make sure that we're taking appropriate precautions to reduce the spread or contact with that patient, to protect our staff as well as our other patients. So what are we doing? As Dr. Keel mentioned, we formed the AU Health System Task Force, as well as the Augusta University Task Force for COVID-19. Our CPAR office, which is Critical Event Preparedness and Response, is working in close coordination with local, state, and federal officials. We're trying to make sure that we keep everyone informed by conducting venues like this. We do have a lot of efforts underway, and there are teams working on a variety of different issues, including making sure that we're educating properly, that we have the appropriate PPE, that we have the appropriate stockpiles of PPE, and that we have the proper processes and procedures in place to deal with any cases that might occur in the local area. We're doing these town halls to make sure that we give everybody the opportunity to ask any questions that they may have. And then Dr. Vasquez is going to be doing a grand rounds on COVID-19 coming up later this month. The simple message, as Dr. Keel mentioned, is keep calm and wash your hands. So we do want to be prepared. We want to make sure that we're prepared for any eventuality that may occur, and that our health system is ready to take care of COVID-19 patients. It really is just a matter of when we have our local case, our first local case, and how many cases we have locally, and making sure that we respond appropriately to those. And again, if you think of this like the flu, this is going to be about 3 to 6 months of a really bad flu season is a way of looking at it. It may tax the system, but we're preparing for it to tax the system, and we'll be ready for that. And with that, I'm going to turn it over to Dr. Joe Vasquez. Dr. Vasquez is the Chief of Infectious Disease and a Professor of Medicine at the Medical College of Georgia at Augusta University. Dr. Vasquez?
So I'd like to give you a little bit of an update as well. Some of it may be a little repetitious, but coming from a different angle, but I'm just going to show you something that I actually pulled up many, many years ago. I was actually involved with the first SARS outbreak. I was in Michigan at that point in time. The big outbreak was actually in Ontario. All right, so if you read Time Magazine for your medical literature, here's what Time Magazine said in 1966. All experts agree that by the year 2000, viral and bacterial diseases will have been eradicated. So what are we doing here? Doesn't say anything about fungi or parasites, but certainly all viruses and bacteria. So it's important to note how it's an amazing world and how it actually changes. So this is what we saw back in 2002. Newsweek Magazine, SARS, what you need to know, the new age of epidemics. We got through SARS, we're getting through COVID-19. Really, and it's important to note, I think the first part of the of that slide, which says, keep calm and wash your hands. Keep calm, and pretty much here at Augusta University, in Augusta really, we're protecting you. We have your back, we have you covered. We understand what's going on. I've been doing this for 30 years, so we definitely will make sure that you are protected, and we do the best possible for not only the students, but for the patients and anybody in Augusta. So this is an electron micrograph of what is a coronavirus. And the coronavirus, the reason it's corona is because you're looking at that little outer area. It looks like a crown, or corona in Spanish. Those spikes are actually the key that attaches itself. Those spikes attach themselves to the lower respiratory tract. That's why this disease produces much more pneumonia than it does upper respiratory tract symptoms. Those spikes have a tendency to attach themselves to the lower respiratory tract all the way from the bronchi down into the alveoli. So this is a classic electron micrograph. It's a beautiful picture, if you want to think of a beautiful virus, actually, if you will. But it is a nice picture of coronavirus. So as Dr. Kuhl said, it is a newly described, it's an RNA virus instead of a DNA virus that causes these respiratory infections. Initially, although we were told about it at the end of December, January, by looking at the literature now, it looks like it was brewing back in November of 2019. It just took them a couple of months to figure out what the heck it was and what it produced at that point in time, because if you recall back to December, January, we thought everybody was eating bats, and that's why they were getting that. Well, it turns out it wasn't that. So it is linked with, and the DNA is linked with bats, with bat genetics and sequences, and also with snake sequences. But nonetheless, we think that probably where it started back in November, which is really the middle of respiratory tract infection season, right? So that's the importance and the differentiation of flu. So how contagious is the coronavirus? We usually in epidemiology use what's called an R-naught. And R-naught is how many folks can you infect, can one individual infect? And what we see here is top of the list is measles. So I guess my take-home message here for the anti-vaccine crowd is vaccinate everybody against all these infections. So especially measles, so you can see how quickly one individual can actually infect 12 to 18 people. So you can imagine what one individual can do and how they vaccinate. Smallpox is another one, polio, mumps, HIV/AIDS, 2 to 5. SARS-CoV-1, the first one was at about 2 to 5. The second one is somewhere about 1.4 to 2.5, although it's speculation at this point in time because we don't have the data. And the one that we all feared, which was Ebola, about the same, about 1.5 to 2.5. So one individual can infect 1.5 to 2.5 people, so 1 to 2 people. So that's how contagious, and that's the contagiousness of this type of coronavirus. Incubation period, I think Dr. Kuhl. The important part to this is the exposure to virus right away. The key to a lot of the community, probably the community setting, is the fact that 1 to 2% of individuals, probably more kids, are asymptomatic. And if you're asymptomatic, you're around, you're at school, you're at work, wherever you are, and you're passing that virus along to individuals. And that becomes really important. We don't have the data here in the United States. We learn our rates are probably going to be about the same thing. So 1 to 2% of the population may actually not be infected, but colonize or low-grade infection with the coronavirus and have no symptoms whatsoever. As Dr. Kuhl said, about 80% will have a low-grade respiratory tract infection, a cold, where you could actually go to work, which is what you're not supposed to do. So the other part of this is, if you're, you have no idea how many people have actually sent home the last 2 weeks because they are stalwart, they're stubborn, they want to come, they want to do their job, they're needed at work, they're not needed at work because one person will infect 2 to 3 people. So staying at home with a low-grade temperature and a flu or cold is really important in this day and age. And then you can see the incubation period. So we think it's somewhere in that range of 2 to maybe 14 days. The spreading is the key. It's via respiratory tract. Manifestations, the 2 classic manifestations that we always ask everybody is, do you have a fever? Even if it's a documented fever at home, and usually a lower respiratory tract symptom, a cough, chest pain, speed of production on occasion, breathing difficulties. After that, it could actually be anything from nausea, vomiting, diarrhea, abdominal pain and cramps, but that's really uncommon. The pneumonia becomes severe in about 10 to 15% of individuals. Some of these patients can actually end up in the ICU with kidney failure. But really the key, the bulk of most of this is going to be respiratory tract, lower respiratory tract with a fever. Sore throat and cough can happen to anybody. And if you look at those manifestations, they're really not much different than other manifestations that we see with the respiratory tract. So this is kind of an interesting figure here. What we're looking at here is the fatality rate across all the different ages, and my pointer's not working, but if you look at down to the right hand on the bottom, those are individuals that are 80 years or above, where the mortality rate is about 15%. Those are the hardest hit. So any patient that's 80 years or above, mortality rate is about 15%. Drop down to the 70 to 79 year, you can see it actually is almost half, about 8%. Go up to the top, up to the left-hand side there, it's something that we've been talking about. For some reason in kids, below the age of 20, the mortality rate is about 1%. So it doesn't seem to attack very aggressively kids from zero, basically, neonates, all the way up to the age of 19. And then you can see how at even 20, 30, and 40, it's in the 0.2 to 0.4%. Influenza mortality rate on an average is about 0.5. So it's a lot less than influenza until you get up to the age of 50 or above. Now, where else we have seen the high morbidity and mortality in the ICU is patients that have underlying comorbidities or underlying diseases. Underlying lung disease, liver disease, kidney disease, so patients on dialysis, stem cell transplant, solid organ transplant, so immune compromised patients, those patients really, we have to be careful because those patients have rates of mortality much closer to the older adult in the 60 to 80 year range. So if you know somebody, family member, relative, you probably should be very careful with the, with the exposure. The diagnosis, we don't have any good one locally at this point in time, but it's important. We still are in respiratory tract infection, and the first thing we do with anybody coming in with what's called the PUI, or the person under investigation, is ruling out commonly known respiratory infections. Influenza, we're still seeing quite a bit. We see adenovirus, respiratory syncytial virus, human metapneumovirus, chlamydophila, and mycoplasma. So 2 bacterial infections we still see during this type of season. So all those things have to be ruled out before we say, okay, this patient may actually have coronavirus. How do we do it? It's not a blood test, it's actually a nasopharyngeal swab. And I want to point this out, it's important to know how the swab is done is very important. This is not a swab of your anterior nose. This is actually a swab of the posterior part of your throat and your nose, which means if you do it correctly, you're going to cry, okay? Or you're going to yell, or you're going to gag, because we actually need to pick up cells. If we don't pick up cells on the swab, we can't do the PCR test in that setting. So it is not an easy procedure. If you've ever had a nasopharyngeal swab, it feels like it's going right into the back of the brain, okay? So that's what it felt like. We got it, okay? So that was a good specimen that we got. If it did not, and you had no symptoms, no crying or anything, it was not a good specimen. Why is that important? Well, it does us no good to collect poor specimens, right? If we collect poor specimens, we're going to have a bunch of negatives. We don't even know which patient, so because it's not a blood test. And then what we'll do is we'll run the PCR assay, which hopefully once we get it locally should be 2 to 4 hours. The testing is now being sent to the state health department. That takes about a day, depending on the time of the year. So the big problem again is making sure we don't swab the anterior part of the nose. I think, as an example, I was going to bring Dr. Poole up here and try it on him. Or President Keel, maybe we'll volunteer for that, but just in case anybody's, but it's significant. So we don't have any point of care testing. In the future, I think we'll have antibodies, so we will be able to do IgM and IgG. That's nowhere near what we used to do. Finally, treatment, as I mentioned before, as Dr. Poole mentioned, vaccines are probably at best 6 months to 12 to 18 months out. They're just getting started. Remdesivir is a drug that's being evaluated. Initially had been studied for the SARS and for Ebola. Being looked at now. I think one of the treatments, hopefully, that we may have is what I call summer burnout, which is when we lose a lot of the respiratory viruses, right? And it gets warmer, people are out, there's actually social distancing because you're in the parks and you're out there instead of everybody cooped up in classrooms, everybody cooped up in houses. So hopefully it'll start to dissipate. If I recall, the last SARS, the last cases were in June and July. So hopefully by the middle of the summer, maybe we'll have some of that. Finally, how to avoid, wash your hands frequently. Yes, there's no antiseptic left, but there's a lot of soap left in Publix and Kroger, okay? And actually, soap is just as good as the antiseptic until you can't take it with you. It works just as well. It's a very susceptible virus because it's got this fat layer, and the fat layer is broken down by soap. So if you don't have the alcohol-based antiseptic, washing your hands with soap and water, 20 seconds. You can count, you can sing, whatever you want to do that takes up 20 seconds, but go ahead and do that. No handshaking, as I mentioned before. Etiquette as far as sneezing and coughing in a napkin somewhere else besides somebody's face, okay, which happens and is not unusual. Avoiding big groups is a possibility. I would say if you are in the 60 to 70, 80-year-old range, you probably shouldn't be going on a cruise. Okay? I'm sure they're cheap and you can probably get like a 2-week cruise for $100. But you can end up with a 14 to 28-day paid vacation if you go on a cruise right now. Just look at what's happened. So probably none of that. A lot of our meetings are actually being canceled all across the world, from infectious disease to cardiology to rheumatology. And I think more importantly, please don't use a mask. So I don't see anybody in this room that's using a mask, which is fantastic. We don't have any in Augusta anyway, but actually, it's a good thing. Leave the mask for the people that are sick or the healthcare workers. And you certainly shouldn't be buying those N95s that are going for a couple of $100, on Amazon. You don't need the mask. The masks go on people that are sick, right? The masks go on the healthcare workers to prevent them. Wearing a mask, especially if you have, like I do, I have a beard. If I have growth, it doesn't work because it leaks. All right, so as a matter of fact, if I go see a patient, I'm going to have to either shave or use one of the other forms, which is called a PAPR. It's kind of like what you see on TV, when everybody else is doing it, covers your entire, but don't use a mask, you're actually just increasing it. Last but not least, so this is hand hygiene, and this is what we need to pay attention to. When you wash your hands, areas less likely to be missed, you can see, and then areas more likely to be missed. So besides washing your hands this way, and between your hands is very, very important. Anterior and posterior at the same time. So it's important to know, if we do wash our hands, wash them correctly and wash them adequately. So this is something that was actually picked up, we actually picked this up from the old SARS, and I've had this for almost 20 years. We are sorry, no shaking hands today, a smile and a nod. A nod will do. And same thing holds true. A smile and a nod or a smile will do. Just a little bit real quick, what we're trying to do here is keep calm. And so the public perception